Thanks everyone for coming today, and thank you, Carol, for the really warm introduction. This is one of my favorite events. I've been coming for many years, and I'm very excited at the opportunity to contribute to it in a slightly different way this year. I'm going to share with you some recent findings. Louder? Okay, is it better? Yeah. Okay. Well, again, thanks everybody for coming today. I'm very excited to see everybody. I've been coming to this event for many years. I'm very excited to share some of the recent work in the field of type 2 diabetes, and in particular, what I do. First, I'll start with the basics of type of diabetes. What is diabetes? How does it work? What types of diabetes there are? And then do a little bit of diabetes in numbers. How many people have diabetes? How are they distributed? Spend a little bit of time speaking about complications, because that's really why we care so deeply about type 2 diabetes. I'm going to talk a little bit about the risk and protective factors. And then my particular angle here is the role of psychological factors in diabetes, or my work really is at the intersection of physical and mental health. Then I'll finish off with a couple of take-home messages, which is what I really hope you remember from my talk. I know you're not going to remember the numbers, so I'm really hoping you take home some of the key messages. And then most importantly, we get to eat lunch. So what is diabetes? Very simply put, diabetes is a disease in which the body is unable to convert food to energy appropriately. This is the simple explanation. How does that happen? Well, after we eat, food gets converted to glucose or sugar in the bloodstream. Insulin gets produced in response to those rising levels of sugar in your bloodstream. And insulin is what allows glucose to pass from the bloodstreams into the cells where it's used for growth and energy. However, in diabetes, this dance between insulin and glucose doesn't work very well, and as a result, glucose gets built up in the bloodstream, overflows into urine, gets flushed out of the system without ever achieving its mission to fuel the body and to help the body repair itself and grow. There are different types of diabetes. The hallmark of every one of them is an excess of glucose. So the levels of glucose in your bloodstream are exceeding an agreed upon threshold. However, the underlying pathologies in the different type of diabetes differ greatly. So my talk today is going to be on type 2 diabetes, which is usually the type of diabetes you hear about. It's the most common type of diabetes. Between 90 and 95% of people who are diagnosed with diabetes have type 2 diabetes. It happens when the pancreas doesn't produce enough insulin, or the insulin is not properly processed by the body. As opposed to type 1 diabetes, which is relatively rare, the risk factors are very different, and for some reason that they don't quite understand, the pancreas shuts down and stops producing insulin. A transient state of diabetes is gestational diabetes, which is diabetes you get sometimes when you're pregnant. Why is diabetes so important? Why do we spend so much money and so much time on diabetes? Diabetes is initially a very silent disease, so for many years you might not even know you have it, and we're going to see later on with the number of undiagnosed people. You might have diabetes, you don't know it. The problem with it are really those complications. Diabetes is among the leading causes of adult blindness, kidney failure, amputations. It's also, people with diabetes have a 2 to 4 times higher risk for stroke or heart disease, and these are complications that are costly, they're deadly, they really can mess up your life. Diabetes is unfortunately very common. Over 29 million people just in the US have diabetes. That's about 1 in every 10 or 11 people. Among older adults, that number is even much higher, about 25% of people 65 and older have diabetes. Unfortunately, 1 out of 4 don't even know they have diabetes, which is scary because it means that these are people who are not making the lifestyle changes needed to make sure that they reduce the risk for complications down the road. A further 86 million people have prediabetes, It's this transient state between normal glycemic control and diabetes. It means that your glucose levels are not quite high enough to exceed the threshold to qualify you as a diabetic, but they're also not normal. And most people who have prediabetes don't even know they have prediabetes, which is again scary, and it makes it unlikely that we have seen the worst of the diabetes epidemic. Without some type of lifestyle changes, exercising more, eating better, losing a little bit of weight, between 15 and 30% of people who have prediabetes will develop diabetes in the next couple of years. However, the good news is that if you have prediabetes, a little bit of healthy eating, being more active, losing a little bit of weight, and you can cut your risk for type 2 diabetes by half. Now that I have hopefully persuaded you that diabetes is a big deal, let's spend a little bit of time thinking about what the key risk factors are. Type 2 diabetes is multifactorial. What that means is that there are many different factors that play into the etiology of type 2 diabetes. And I think most of the risk factors are familiar to all of us. They include having a family history of diabetes, not exercising enough, leading sedentary lifestyle, having a diet that's mostly unhealthy, having a little bit of extra weight, particularly around your abdominal area. These are all factors that have been very strongly linked to increased diabetes risk. Obesity in particular is a particularly strong risk factor, and I think it deserves a stronger look. I have some really cool looking maps from the Centers for Disease Control that show the really close relationship between obesity and diabetes over the years. So what we're looking at here is lighter colors, less people, darker colors, more people. That's the simple way to look at those maps. What we see here is that in 1994, most of the states had a prevalence of diabetes, of obesity, that was less than 14%. What that means that in those states, only less than 14% of the people met the clinical criteria for obesity. Fast forward to 2013, which is barely 2 decades later, and we see that most states have a prevalence of over 26%. And that's a very, very drastic difference, and we'll see how that plays out over time. But if I put down the maps for diabetes, we see that they look very similar to the maps for obesity. Very few diabetic people in 1994, an explosion by 2013. And I think it's really fascinating. I'm a data geek, so I find weird things fascinating. But I think it's really interesting to look at those maps over time and see how there's darkening on the left side. So we see more and more people becoming obese. And then in just a couple of years, we see that the map for diabetes is catching up. As more people are becoming obese, more people are becoming diabetic. It's a very clear causal relationship, which is very well accepted in the field. It's really quite striking how quickly the colors are changing. Now that I've sufficiently scared you, well, type 2 diabetes is preventable. And how do we know this? Enter the Diabetes Prevention Program. And this is a program I have not been involved with, but I'm very excited about. It was the first study to actually show that type 2 diabetes is preventable. The researchers asked a very ambitious question. They asked, can type 2 diabetes be prevented or delayed in adults who are at risk of developing type 2 diabetes? The Diabetes Prevention Program, or the DPP, was a randomized controlled trial, or an RCT. This is the gold standard for clinical trials. It costs the most money, it's the hardest to put together, but it's considered the most reliable form of scientific evidence. So we trust the results that are obtained by an RCT because of very strict research design issues. It involved over 3,000 participants, and every single one of those participants was overweight and had prediabetes. And by now you know what that means. They were well on their way to develop type 2 diabetes in the next couple of years. They came from 27 different centers around the country. Participants were randomly assigned to one of 3 groups, and here again, where research design is key. Every participant was assigned to only one group. So what happens is over time, we follow the people, the participants, we compare their rates of diabetes, and we can hopefully ascertain that the different rates of diabetes we are looking at can be traced back to the intervention they were a part of, because every single person was a part of a different group. The first group, the group we're particularly interested in, is the lifestyle modification group. These were the participants who received the fancy lifestyle coaching. They received very intensive training in diet, physical activity, and behavior modification. They were coached about how to make healthier choices. They were coached how to exercise more efficiently. They were coached how to cook better. They were coached to pick up on behaviors that are unhealthy and that are detrimental to them. They were exercising 150 minutes a week at least, and trying to eat less calories. They were not given any pharmacological treatment. They were just a lifestyle modification group. They were just taught how to live healthy. The second group was the metformin group. So these were the people who were given the best in pharmacological treatment of diabetes. They were given a metformin pill twice a day. They were given only the standard information on diet and exercise. So they did not receive any fancy coaching. They were not given any tools about how to live better. They were told what pretty much any of us is told when we go to the doctor's office. Yeah, you gotta eat better, exercise more, lose a little bit of weight. You know, this is the level of information they received on diet and exercise. The third group is the group that really didn't get anything. They did not, they were given a pill, but it was a placebo pill, meaning it had no active ingredients. So it was not a pharmacological treatment of diabetes risk, it was just a pill that wasn't doing anything to their underlying physiology. And again, they were given the standard information on diet and exercise. Go be healthy, we're not going to tell you how. Again, to make sure we're all on the same page, the big goal was to compare rates of diabetes between the people who were not coached or given a pill, people who were just given a pill, and people who just received the fancy lifestyle coaching. This is the benchmark group. This is the group we're going to compare all the other numbers to, because these are the people who really didn't receive anything. So they're our average group. What are we going to find about their rates of diabetes? And what we found was that 29% of the people in this group had developed diabetes in the next couple of years. Now, the people who were given metformin, they had a reduced risk for developing type 2 diabetes. Only 22% of them developed diabetes compared to 29%. And that's a significant risk reduction of about 31%. So there's evidence that metformin did prevent or delay the onset of diabetes in the people who were given metformin. And I know everybody's really excited to hear what happened to the people who had to sweat and actually put work into their healthy lifestyle. What we found was that only 14% of them developed diabetes. That's a very significant difference. That was a risk reduction of 58%, and I personally find this result so empowering. It shows that you can do something about your health risk. Even if you start off pre-diabetic and overweight, you can do something and have a significantly less risk for diabetes. And I'm even more excited to share the results about on older adults. So with that particular study, when they looked at people 60 and older, they realized that lifestyle modification worked even better for them. Their diabetes risk was reduced by 71%. So for older adults, doing something about your health, exercising a little bit, making a little bit of healthy choices in your meal planning, their diabetes risk was reduced by 71%. And it was explained by the fact that older adults were more likely to actually exercise more and achieve greater weight loss, which ultimately contributed to their lower levels of diabetes. Unfortunately, metformin was least effective for older adults. So I'm guessing that's bad news for everybody who was really hoping they'll pop a pill and then feel better and don't have to sweat. No, science is not quite there yet, and my personal fear is it probably never will be. So really, your best solution is to exercise and eat healthy. And I'm really glad that this was a theme throughout all the talks today, because clearly this is the key to healthy living in all parts of healthy aging in all parts of all different diseases. So by now we all know that we have to find a balance and live healthy. However, many people find it hard to do that. And why is that? Well, if we look back at the list of risk factors, we look at family history of diabetes, lack of exercise, unhealthy eating, overweight. What's very notably missing, and it's very puzzling to me as a psychologist, is that mental health is completely lacking from this picture, which it's really a surprise, given that in at least 3 of the key risk factors, exercise behavior, food behavior, carrying extra weight, mental health is a very key correlate of all these behaviors. Either predicts it, or it's a result of it, or it's just related to it, or coexists with it, but it's certainly there. To address this oversight, clinicians have recently added depression to the list of risk factors, particularly as a driver of this unhealthy behavior. People who have depression have much higher levels of those unhealthy behaviors, which ultimately translate to higher diabetes risk. And depression is usually diagnosed by a mental health professional. I will not spend too much time talking about how depression is diagnosed, but given its importance to unhealthy behaviors and risk factors in type 2 diabetes, I thought it was important to spend a couple of seconds on it. Depression involves feelings of unhappiness, hopelessness, pessimism, low self-esteem. It involves loss of interest in things that were otherwise considered pleasurable or previously considered pleasurable, decreased energy levels, changes in appetite, changes in sleep patterns, little pains that just won't really go away. Turns out, now that we know that depression is a big deal as well, turns out it's very difficult to disentangle the relationship between depression and diabetes. It's hard to tell whether diabetes causes depression or whether depression causes diabetes, and there's evidence to support both camps. We can easily see how somebody who has depression will have a higher risk for diabetes. People who are depressed often have increased appetite, lower energy, higher levels of stress hormones, and these are all risk factors for dysregulated glucose metabolism and higher risk for diabetes. Alternatively, diabetes is a very stressful chronic disease. It's hard to manage, it takes a lot of effort every day, and it's common for people to get diagnosed with depression, particularly shortly after they've been diagnosed with diabetes. So it's safe to say that those two conditions often coexist. We don't know which one is the chicken, which one is the egg. They often coexist, and it's safe to say that the presence of them together makes the management of the other one that much harder. Another risk factor which I have spent some of my personal time working on is stress eating, or the idea that we are eating not in response to hunger, but in response to emotional cues. We eat because we are stressed out, because we are anxious, because we're depressed, because we're bored. We're eating in response to something that is not hunger. And what are the comfort foods we're reaching for? Well, we're reaching for things that are high in fat and sugar and salt, think pizza and donuts. I personally wouldn't trust anyone who tells me they reach for a carrot when they're stressed out. But it makes us feel better. In the short term, it calms your anxiety. It makes you feel better. However, over time, it's associated with weight gain and higher risk for diabetes and many other chronic diseases. And it's also common. 40% of people in national surveys say, oh yeah, of course, when I'm stressed out, I eat a little bit more of my favorite foods. Thankfully, negative emotions are only one part of one's emotional landscape. And positive affect, or the feeling that reflects pleasurable engagement with the environment, has shown some promising links to lower risk for diabetes. It's showing that people who already have diabetes have better glycemic control if their levels of positive affect are higher. It's in one very interesting, well-done study. The risk for mortality among people with diabetes is lower if they have high levels of positive affect. So there's something about high levels of positive affect that seems to be protective in terms of diabetes risk. How? Why? Well, we don't really know for sure, but there is evidence that people who have high levels of positive affect tend to lead healthier lives and have healthier lifestyles. And we already saw how lifestyle changes are big for diabetes risk. People with higher levels of positive affect also seem to have better functioning underlying physiological systems. Their stress hormones are not out of whack, and this is again another influence on glucose levels. But humans are very complex beings. So far we talked about obesity or exercise or risk or familial risk or depression, but every single one of us has a varying degree of each. You know, we're all combinations of all of these risk and protective factors. Now that the main influence, or those individual influences or single influences have been described, you know, everybody knows that obesity is bad for you. Family exposition for diabetes increases your risk. These are single influences which we're all familiar with. So now that this has been mapped out, scientists are attempting a much more ambitious question and looking at combinations of risk and protective factors. So how is your individual risk affected by your particular combination of risk and protective factors? So the key question here is, can the presence of one factor influence the degree to which another one influences diabetes risk? For example, in the DPP, everybody had prediabetes and everybody was overweight, so they had risk factors. But for some of them, those risk factors do not translate into increased risk because they exercised. So the presence of exercise lowered their risk for diabetes. And a lot less is known about mental health, and of course this is the area where I spend most of my days and usually nights on. It's the idea that all of us start with a couple of risk factors. You know, let's say you have you're carrying a little bit of extra weight, your mom has developed diabetes, you don't really like moving too much. So by now you know, this means your blood glucose is inching up. You know, it's probably here, kind of going up, if it's not going over yet. So your blood glucose levels are inching up. As a psychologist, I'm very interested in whether psychological factors are a player in this particular process. It's a very intriguing idea that stress, anger, depression, they are a risk factor that can actually speed up this inching up the risk ladder. You know, it's possible that, you are slowly getting up there, but all of a sudden you have chronic stress in your marriage, at work, with your children, there's something that is really bugging you. And is it possible that stress is this last, the proverbial nail in the coffin that pushes you over threshold levels, or just speeds up the process? You're going there anyway, but it's speeding up your risk for developing diabetes. And there's actually evidence that this happens sometimes. This is one of the first studies I conducted with Carol using her very fancy national study of adults, which we're all thankful for, and many international researchers are thankful for as well. So we looked at the relationship between central obesity and HbA1c, which is one of the markers of diabetes risk. And we thought long and hard about a chronic stressor that is linked to obesity. And we came up with, we realized that there's many people who report being discriminated against because of their body size. People feel discriminated, people are made feel fat in medical settings, in public, in airplanes, and this is a chronic stressor for somebody who's carrying extra weight. So we decided to look at the relationship between obesity, that experience of weight discrimination, and diabetes risk. And what we found was, yes, people who are heavier have higher risks for diabetes, but by now everybody knows that. That's not really what's exciting here. What's interesting here is that people who are the same body size The ones who experienced weight discrimination, that chronic stressor of weight discrimination, had much higher levels of diabetes risk than people who did not experience weight discrimination. And again, these are people with the same biological risk factors. They have the same key risk factors we have controlled for some of the others. And the difference between them, or the difference that we can pick up on, was that experience of chronic weight discrimination. And I find this, and these results were actually obtained at non-diabetic levels. So none of the people in the study had diabetes. They were all inching up, but nobody was quite diabetic, which is very important because that means it's preclinical levels, and that's always the intervention target. Everybody prefers to prevent the disease from happening versus treating it once it happens. So what we're seeing here is that there's a potential for psychological factors to be affecting your risk for diabetes. And in another similar study, we looked at the relationship between BMI and insulin resistance, which is again another measure of preclinical diabetes risk. And what we found here is that, again, people who had higher BMI had higher risk for diabetes. Again, nobody's really surprised. But people who reported a lot of anger, whether they were expressing that anger or suppressing that anger, they had much higher risk for insulin resistance than people who reported, not really having much anger in their lives. And what makes me personally the most excited, and this is an area of interest I have picked up from my lovely mentor Carol, it's the idea that mental health can be good. So we already looked at the possibility that stress can make you go up that ladder of risk. However, there's also the possibility that good mental health can be protected. So let's say you have the same risk factors. You're a little bit overweight, you don't really like moving, your mom has diabetes, you have risk, you have important risk factors, very valid risk factors associated with your risk for diabetes. Here the idea is that good mental health could be protected. So you have all these risk factors, but maybe you have good social networks, you're a happy, calm person, somebody who's really engaged with their community, somebody who has a good family life. Is it possible that these are characteristics that help you lower the risk for diabetes? And there's actually very exciting evidence suggesting that it could be possible. In the last example from our lab, we most recently looked at the relationship between parental history of diabetes and diabetes. And we know that if your parents have developed diabetes, that puts you at 2 to 6 times increased risk for developing diabetes down the road. What we found in our study was that, yes, of course, people who reported having a parental history of diabetes had higher risk for developing diabetes. They had a 3 times higher risk for developing diabetes. However, positive effect emerged as a key factor in regulating their risk levels. So what we see here is that people who had no parental history of diabetes had very low probability of diabetes. They were pretty low. However, for people who had a positive parental history of diabetes, these are the people who have a 3 times higher risk for developing diabetes. The ones who had higher levels of positive effect had levels of risk, of diabetes risk, that were very similar to the people who did not have that very powerful genetic load for diabetes. And that makes us very excited, particularly when we think of non-modifiable risk factors. Because it's hard, but there's things you can do about your activity levels and your diet and your weight. It's hard, we all know it's hard to make those changes, but they're possible. There's not really much you can do about your familial risk. It's just there. And finding that a psychological factor can actually modify the degree to which this genetic risk factor influences your diabetes risk, I personally find very, very exciting. And I have a couple of take-home messages. The first one is that exercise and healthy diet are still the most important. There's no way around it. The current physical activity guidelines for Americans state that we should all be exercising at least 150 minutes a week of moderate exercise. It doesn't have to be anything overly strenuous. I'm not saying we should all be doing an Ironman, but everybody could take a walk. Yes, even older adults. Older adults often state that they cannot meet those guidelines, but doing a little bit is much better than not doing anything. It's really better for diabetes, it's better for pretty much any chronic disease you can think of. And the second message is really trying to appreciate the interplay between mental and physical health. They're very closely linked. They intersect, they influence each other. You know, I'm running out of synonyms in which I can say that. But there are many different ways to develop diabetes. And make sure you're assessing your health, think of your risk and protective factors, and remember, they could be biological, or they could be psychological, or they could be social, but definitely assess where you need to make changes, look for help if needed, and most importantly, have fun while being active.